introduction, and thank you for the organization. I really appreciate this great effort from your side to continue this kind of program despite all the challenges and problems. So about cardiac emergencies, and during the course of this presentation, I encourage you to interact, to stop me if you wish, to ask questions if you wish. And we're gonna start with the hierarchy and sequence of workup. As far as cardiology is concerned, just like medicine, you know, we start with history. History is still and will always be the main pillar of the clinical workup. So the history, how the presenting complaints is, and then we do the clinical exam. It can be focused in context of emergency cases and stuff like that. Can be elaborative in other circumstances that depend on the art of clinical workup. Then we have ECG as an important pillar. We also have chest X-ray, biomarkers, and echo. Up until this stage, the vast majority of cardiac diagnosis will be established. Just in few and rare occasions, we might proceed further seeking the diagnosis or further refinement of already established diagnosis. Echo is pivotal and crucial in the diagnostic process in cardiology. And that's because if it's ubiquitous, it's now present almost everywhere. It's real-time kind of imaging. It's portable, and it's becoming more and more portable. So we have this machine, which is more of departmental and lab-based, but we also have this gadget, and we have the smaller machine, handheld, mobile-mounted echo, and all of these, okay? And this brings us to the POCUS being the fifth pillar of clinical exam, insonation, completing inspection, palpation, percussion, and auscultation. And now we have insonation. And this is not exclusive to cardiology. Now all medical fields are using ultrasound as an important pillar of clinical exam. And like here, for cases of emergency and shocks, they can do POCUS to define the 5 E's. 5 E's stands for effusion, ejection, fraction, equality, exit, and entrance. So in a shock patient, you want to identify is tamponade culprit, that's effusion, the ejection fraction, which might points to cardiogenic shock, the equality, meaning how the RV is no longer equal or smaller than the LV, and this indicates pulmonary embolism. You want to see the exit, which is for aortic dissection, and you want to see the entrance, which is IVC, to decide or to have an idea about the volume status and whether this might be hypovolemic shock. Emergency echo or stat echo, in which you need an echo immediately, according to the guidelines, for any hemodynamic instability of unclear etiology or of suspected cardiac etiology. Or sometimes if the chest pain diagnosis is not so straightforward, you might enlist the help of echo. And of course, in mechanical complication of myocardial infarction and in respiratory failure of suspected cardiac etiology and in pulmonary embolism. And this is a bit controversial because what is pointed at in guidelines is even for proven pulmonary embolism, suspected and proven. We used to discourage using echo for a patient who is already diagnosed with PE, but echo is gonna add an important value in the way of diagnostication and prognostication when it comes to pulmonary embolism. So if the pulmonary embolism is not yet diagnosed, but there is a clinical suspicion of it, echo is helpful in the diagnosis. If the diagnosis is already established, echo is important because it tells us if there is no RV strain, and this will have therapeutic implication. So pulmonary embolism, whether proven or suspected, is an indication for echo. Now, emergency can arise anywhere, anytime. It's not about emergency room, okay? The most common cardiac emergency by far and away is acute coronary syndrome. We also have heart failure. We can have arrhythmias, different forms, the most common of which are atrial fibrillation and blocks. We can have also pericarditis, myopericarditis, and pericardial effusion, which are now grouped all together as IMPS, inflammatory myopericardial syndrome. Valve disease can present acutely in form of decompensated heart failure and pulmonary edema. We can have hypertensive emergencies. We can have acute aortic syndrome like dissection, ulceration, hematoma, and this is probably is going to be dealt with separately in discussion. We can have pulmonary embolism, and there are some others. Now we start with the first case of a 41-year-old man with chest pain after 2 days of flu-like symptoms. His pain is sharp, it increases on coughing and deep inhalation. So according to the clinical scenario, it seems straightforward that this is so suggestive and so consistent with pericarditis. Now let's have a look at the ECG. The ECG again, if you wish to interact, most welcome. What we see in here is what? We are seeing ST elevation, which is here, basically, but also somehow in the inferior leads. We also have, you see here, PR depression or sagging of the PR, elevation of PR in AVR, yeah? So along with the clinical history, this is a case of pericarditis. Clear, straightforward. Now, what are we going to do next? So the diagnosis is established based on clinical data, based on ECG. We should always have echo and troponin. Okay, this is going to be for prognostication. Yani if a patient having pericarditis but has large pericardial effusion is different than a patient who has pericarditis and no effusion. A patient with pericarditis and no troponin is different than a patient of pericarditis and high troponin. Okay? So the causes of pericarditis are many, but the most common are idiopathic and infection, in particularly viral infection. It can also be part of renal failure and an acute myocardial infarction. You can have an acute myocarditis, which is related to direct irritation of the pericardium by the inflamed and necrotic myocardium underneath. And you can also have pericarditis that comes late, the so-called Dressler syndrome, and this is kind of immune response, okay? Neoplastic syndrome can also lead to pericarditis. Post-cardiac injury syndrome, which is called post-cardiotomy syndrome after cardiac surgery, and this is similar to Dressler syndrome and bears the same mechanistic etiology, which is immune reaction, okay? Pericarditis can be part of connective tissue disease and after irradiation. Now, most important to know that when we have myocardial infarction or ischemia, the pain tends to be pressure-like heaviness. But in pericarditis and in pulmonary embolism, it is sharp and stabbing. Okay, and also the pain of pericarditis changes with breathing. So it increases on inhalation, and also it's positional pain. So it increases on lying supine and eased when the patient is stoop forward or lean forward, you know. These are all important discriminating features, and I think it isn't difficult to distinguish between the pain of pericarditis and the pain of myocardial ischemia. Now, how we diagnose, we have here, if you see, we at least have to have two of the following four criteria. So the characteristic chest pain, which is sharp, positional, respiratory related pain. You can also elicit precardial friction rub, ECG, very suggestive features of ECG, and you can have echo showing new or worsening precardial effusion. So two out of these four establishes the diagnosis of pericarditis. Now you also have to look for high risk features because this is going to tell you, are you going to admit or discharge this patient on follow-up? And these risk features are fever, leukocytosis, light precardial effusion on echo or cardiac tamponade, pericarditis complicating trauma, patient on oral anticoagulation or non-steroidal therapy, elevated troponin, and relapsing pericarditis. So these are high-risk features in which you may need to admit the patient and treat in hospital. طبعا the treatment is basically non-steroidal and colchicine, but sometimes we might need to use prednisolone and immunosuppressant medication and even more advanced therapies in very complicated and refractory cases. Second case, 72-year-old male admitted to oncology ward for knee sarcoma pending his chemotherapy cycle. He complains of increasing shortness of breath for 3 days. On examination, blood pressure is 90/55, heart rate is 120 beat per minute. He has raised JVP and muffled heart sound. So what is this? Let me hear from you. So what do you think? What do you think about this patient? What do you suspect based on this clinical scenario? That reminds us of the Beck's triad. Yeah, the Beck's triad in which you have raised GVP, muffled heart sound, eh, in a patient of tamponade. So this patient is having raised GVP. He is not congested in the lungs. He had muffled heart sound and he's hypotensive. Yeah, so this is very suggestive of tamponade. Okay. And remember, in tamponade, you are going to have a gradual increase in intraprecardial pressure corresponding to a gradual increase in, sorry, if you can mute yourself, please. So as the precardial fluid increases, there is a gradual increase in intraprecardial pressure. And with the increase of intraprecardial pressure, we have a decrease in the RV filling pressure and the LV filling pressure. طبعا the RV is more prone to tamponade because of its being thin-walled and more compressible than the LV, which is more muscular. But as the tamponade process, it affects the LV too. The problem with tamponade is that look at this curve, which is really, these curves are really alarming because when the intraprecardial pressure increases, the RV pressure increases and the LV filling pressure increases, and then we suddenly reach a stage in which there is a precipitous decrease and decline in cardiac output, which is shock. When are we going to reach that stage? It's very difficult to predict. Very difficult to predict. This is cardiogenic shock, okay? Therefore, we have to look at the precardial effusion and its hemodynamic repercussion as a broad spectrum process. It's not all or nothing. It starts gradually and it builds gradually, but there are a stage of unpredictability and uncertainty at which it can suddenly lead to cardiogenic shock. But we know that the larger the fluid, the more likely to compress the heart. The faster it accumulates, the more likely it compresses the heart. So we have the size and the rate of accumulation. And some people think that the rate of accumulation is probably more important than the size because if it accumulates gradually, there is more time for the precardium to stretch. So the reserve of precardial stretchability is longer. But when it accumulates in a rapid pace, the pericardium has no time to stretch and its capacity is exceeded faster. So the curve rise steeply if the fluid accumulates rapidly. So it's a matter of size and speed. Both are important. Now, when we look at this arterial pressure waveform, and this one is beat to beat variation of the pulse, this is called pulsus alternans. This sign can be seen in the screen in a patient attached to hemodynamics, or can also be elicited clinically by palpating the pulse. So you are going to see uh, a strong and weak amplitude pulse going alternatively, and this is pulsus alternans, which is a sign of severe LV dysfunction, probably leading to cardiogenic shock. Now we can also elicit this sign clinically by the pulse and by the sphygmomanometer, which is pulsus paradoxus, in which you see a decline in the blood pressure during inspiration, and any decline more than 10 is considered significant. This is called pulsus paradoxus, which is the clinical sign of tamponade. The clinical sign of tamponade. طبعا you can, as we said, you could elicit it by sphygmomanometer, but in advanced cases, you can also feel it in the pulse. When you put your hand in the pulse during and you ask the patient to take a deep breathing, you see that the amplitude of the pulse goes low and it comes back again during expiration. Yeah. We can also see this one here. If you do an ECG for a patient of a fluid as large as this and a heart as moving as this, you are going to see the so-called electrical alternance. And I don't want you to conflate electrical alternance with pulsus alternance. They are completely different entities. Electrical alternance is an ECG sign and no clinical sign. Pulsus alternans, on the other side, is a clinical sign and not an ECG sign. Okay, so this electrical alternance is thought to be due to the ECG being here and the heart is moving closer to and away from the ECG. So you are seeing high amplitude and low amplitude. And of course, when we have a large effusion, we also have low voltage ECG in general. In general, we are going to have low voltage, which is defined as less than 5 millimeter in the limb leads and less than 10 millimeter in the chest leads. Anything like that is suggestive of large precordial effusion. The chest X-ray sometimes can be so characteristic by demonstrating the flask-shaped deformity, and this is the silhouette of the heart when it is filled of precordial fluid. Now, the analysis of tamponade by echo, and I don't want to bore you with the details of it, but generally speaking, we have so many measurements, including the RV diastolic collapse in the parasternal long axis. When we see this sign that the RV is collapsing in diastole, this is an important sign of tamponade. We also have this RA collapse, but we have to quantify it. It's not a matter of present or absent because it can present in a very small innocent diffusion. But if it remains, the RA remains compressed for a long time, which is defined as more than 1/3 of RR interval, more than 1/3 of cardiac cycle. That is very specific of tamponade. We also look at the IVC. If we have tamponade, the IVC is plethoric. It's dilated and non-collapsible. And we also have mitral and tricuspid respirophasic changes. So during the during inspiration, the flow decreases across the mitral valve by more than 30%. And during expiration, the flow decreases in the tricuspid through the tricuspid valve by more than 60% if you have full-blown tamponade or nearly tamponade. So if we look at the echo features which are in here and their assigned sensitivities and specificities, the most important two are these. The duration of diastolic collapse of the RA if it is more than 1/3 of RR interval, the specificity is 100%. A specificity means it rules in. It rules in tamponade. So if you see it, that is tamponade. Now look at the IVC. IVC plethora sensitivity is 97, but specificity is low. That means what? IVC is very important to rule out tamponade, to rule out, not to rule in. Sensitivity, ruling out. Specificity, ruling in. So if we have a sensitivity of 97, معنى ذلك إيش؟ If I look at the IVC and it is not plethoric, that probably rules out tamponade. That probably rules out tamponade, especially in a very few circumstances if you have a localized diffusion or patient is hypovolemic or stuff like that, okay? But remember, a plethoric IVC does not necessarily mean tamponade, because it might be due to severity R, it might be due to hypervolemic status, might be due to mechanical ventilation. Yeah, so specificity is not high, sensitivity is high. The specificity, the highest specificity goes for the diastolic collapse of the RA if it's quantified and found to be more than 1/3 of RR interval. This rules in tamponade. And of course, now pericardiocentesis, if indicated, we go for it echo-guided. It's not blind, it's not by fluoro. The best is to go by echo-guided, because echo-guided pericardiocentesis is safe. It allows us to determine the depth and the location of the largest pool, and it guides us to where we insert the needle. So this avoid complication, avoid piercing the LV or RV and all of these sinister complications. Now we have a heated debate arose between the cardiologist and ER physician over the possible etiology of elevated troponin in a patient who came in with severe UTI accompanied by pyrexia and tachycardia. The cardiologist claimed it was non-cardiac troponin due to sepsis, while the ER physician insisted the heart must have a serious problem. Which side of the argument will you take? The cardiologist, the ER physician, none, both, or you prefer to be a fence-sitter? So what is going to be your stance? So what do you think? So the elevated troponin is
Like a
problematic.
YouTube search.
Sorry? تفضل يا قاسم. Yeah, the elevated troponin is.
Assalamu alaikum wa rahmatullah.
وعليكم
As
السلام.
an ER physician, I believe it might be the cause of sepsis. So I'll go with the ER physician.
With the ER physician?
Yes.
ER physician insists that the heart has a serious problem because of elevated troponin.
We don't have enough history, لكن history wise كده من الموجود ده. I'll go with the ER physician.
Okay, great. So you are so loyal to your specialty, and this is great. But
Actually,
in fact,
both might be right, yeah, Hatim.
yes, both may be right? But in fact, I prefer that we are not gonna take the side of any of the two, because the troponin can be elevated due to pyrexia and sepsis. Yeah, we know that. But the cardiologist saying that it is non-cardiac troponin, that's a wrong statement. It's a cardiac troponin, but the injury is different. So when we talk about troponin, we have to put it back in clinical context. We know that the troponin we have, these are sarcolemmal proteins, and we have troponin C, T, and I, okay? The one that we use for ischemia and infarction detection are the T and I, not the C. Why? Because C is not lack cardiac specificity. It's present in skeletal muscle, the same isomer. So it cannot differentiate between muscle and cardiac. What is cardio-specific troponin is T and I. And troponin T is more commonly used than troponin I, and this is probably relates to the logistics of the lab check itself. But both are cardio-specific. Some people even think that troponin I is more specific than troponin T, but both are cardio-specific. Now, we have to remember that elevated troponin is a marker of injury. So we are having kind of myocardial tissue necrosis, okay? And can be elevated due to a lesion of cardiac and non-cardiac etiologies. So we have acute coronary syndrome, myocarditis, heart failure, myopericarditis, cardiac contusion due to trauma, tachyarrhythmia if severe enough, cardioversion after CPR, after cardiac surgery, and all of these. We can also have it elevated due to sepsis, trauma, CVA, chronic renal failure, pulmonary embolism, severe critical illness, rhabdomyolysis, extensive burn, envenomation, severe hypertension, carbon monoxide, ketoacidosis, COPD, and severe anemia. So that brings us to an important and crucial point. Troponin should be always contextualized. Yani you cannot interpret troponin in isolation of the full clinical scenario, okay? But remember, if it's elevated, it comes from the heart. It comes from the heart. So it's not right to say this is non-cardiac troponin. It's cardiac troponin, but it's not due to ischemic injury. It might be due to sepsis. Sepsis means what? How sepsis elevates the troponin? By imposing a cardiac injury. It injured the heart. Lakin not through ischemia, okay? Through other mechanisms. So the mechanistic pathways for cardiac injuries are many. Ischemia is one, but there are so many non-ischemic injuries. But remember, troponin, T and I always come from the heart. Okay. Now, this also brings us to discuss a little bit about the pro-PMP and PMP. These are markers of stretch. So whenever the heart or any cardiac chamber is under stretch, we expect that troponin gets elevated, the elevation of which corresponds to how much of a stretch do we have. So we expect that to be with congestive heart failure, and in heart failure with reduced ejection fraction, we expect it to be higher than with preserved ejection fraction. In acute coronary syndrome, can also be elevated. In hypertrophic cardiomyopathy, restrictive cardiomyopathies, in constrictive pericarditis, in valve diseases like severe MRTR and AS, in severe fast atrial fibrillation and cardiac amyloid. But we can also have this chamber stretch due to COPD, pulmonary embolism, pulmonary hypertension, sepsis, hypertension, subarachnoid hemorrhage, renal failure, liver cirrhosis, and paraneoplastic syndromes. So we come to this case of a 55-year-old male, diabetic hypertensive with dyslipidemia and smoker, presented with chest heaviness and profuse sweating. His vitals are stable. Blood tests are unremarkable apart from mild leukocytosis. And remember, leukocytosis can be stress-induced due to demargination, so it's not always a matter of sepsis and infection. Troponin is 3, and ECG is normal. So this is acute coronary syndrome. In particular, this is non-ischemic. The chest pain is cardiac, troponin is elevated. So this is acute coronary syndrome, non-ischemic. So we have 3 phenotypes of acute coronary syndrome: unstable angina, non-STEMI, and STEMI. All present with chest pain, which can be cardiac, but can also be kind of atypical and possibly cardiac, okay? So it's not always typical or cardiac kind of chest pain. So you have to be cautious when you are analyzing the chest pain, okay? But in unstable angina, we know that the ECG can be normal, ONCAR be abnormal, but the troponin is normal. Non-STEMI, chest pain, normal or abnormal ECG, but elevated troponin. STEMI, chest pain with ST segment elevation with elevated troponin. And now in term of injury, usually when you have unstable angina, the myocardium is intact. So there is no established necrosis, although there is obstruction, but not severe enough to induce necrosis. In non-STEMI, you have necrosis, but it is not transmural, it is subendocardial necrosis. That's why it was referred to historically as subendocardial infarction, which was later replaced by the term of terminology in STEMI. And STEMI is transmural infarction, so you have a transmural kind of injury. Okay, that's why you have ST segment elevation indicating a cavitation of this part which is necrotic. Okay, so these are the three phenotypes of acute coil syndrome. And pathologically, we know that when we have a atheroma that accumulates over time, over time, usually we go in this direction or this direction. Sometimes it remains stationary for quite some time, but the atheroma builds up gradually, and this encroach upon the lumen. So the lumen gets narrower and narrower and narrower. But if this narrowing of the lumen goes gradual this way, we are in the direction of chronic coronary syndrome. The problem is atheroma of any size, large or small, if it's vulnerable enough, it may rupture. And rupture is a sudden biological accident because it immediately triggers a coagulation cascade. So from atheroma, we are transformed into acute thrombus occlusion of the vessel. And this shifts us from a stable kind of clinical course into acute coil syndrome. اوكي that's why by the way يعني سابقا كان يقول لك stable ischemic heart disease and acute coronary syndrome الان سموهم نفسهم acute coronary syndrome and chronic coronary syndrome عشان to emphasize that the underpinning pathology is the same, it's just different tracks. هنا بيمشي ل thrombus formation because of plaque rupture, وهنا it remains gradually building up leading to chronic coronary syndrome. Yeah, but the underlying pathology is the same for both of them. And this also brings us to يعني اللي بيحدد انه الواحد يمشي في chronic coronary syndrome ولا acute coronary syndrome is not the plaque size only, it's the vulnerability of the plaque. Okay, the vulnerability. That's why the concept of vulnerable plaque is gaining lots of holds in cardiology, and they want to investigate for it by all kind of imaging armamentarium. لكن عموما نحن we know that the plaque is composed of a fibrous cap, a fat core, and cellular content. So the smaller the fibrous cap, the more of lipid core, and the more of cellular content, the more vulnerable the plaque is. Okay, that's the vulnerable plaque, the concept. Now for chest pain analysis, of course, the chest pain analysis rests almost heavily on the data, clinical data. Yes, clinical data is important. So how the chest pain is being central, pressure squeezing, gripping, heavy, tight. These are more suggestive of ischemic kind of chest pain. But when we go to the description like sharp, fleeting, shifting, positional, it is unlikely to be cardiac chest pain. But in the chest pain analysis, along with the characteristic of chest pain, we also have to look at the ECG and the biomarkers and the risk factors. And the risk factors are here. So in the chest pain analysis, you have to encompass the characteristic of the chest pain, the risk factors of the patient, the ECG, and the biomarkers. After which, you are going to decide about the best course of action. Okay? And as per the new guidelines, we used to call or to describe chest pain as one of three categories: typical, atypical, and non-cardiac. But now they discourage us from using these terminologies, and instead we are describing chest pain as cardiac, which was previously called typical, possibly cardiac, which was previously called atypical, and non-cardiac. And this shift is kind of conceptual shift. ليه؟ لأنه لما كنا بنقول atypical chest pain يعني it's kind of reassure the clinician على إنه this is you know what خلاص ما في مشكلة كبيرة. لكن they found out that the vast majority of acute coronary syndrome are actually atypical chest pain. So خلينا نحن we align our terminologies بحيث أنه يكون serious enough. Possibly cardiac export a message of إنه you are not done with your job yet as a clinician. Look further. It's not like atypical chest pain. لما تقول atypical chest pain خلاص انت you heave a sigh of relief and things are fine, you can discharge your patient. Like when you say possibly cardiac, معناه I have to look further, I have to investigate further. So now chest pain is divided into cardiac, possibly cardiac and non-cardiac, and no longer typical and atypical. Okay? But that's important. So the course of action is based on the pre-test probability. So the pre-test probability determines the next course of action. Okay? That's important جدا يا شباب لأنه when we use Bayes theorem of post-test probability يعني the value of the diagnostic test whether positive or negative depend on the pre-existing clinical probability. يبقى خلي دائما الclinical probability your firm grounds upon which you interpret all the upcoming test وليس the other way around. So if you skip history and the clinical data, you get lost. So we have this 35-year-old gentleman, no risk factor for coronary artery disease, presented with stabbing chest pain, ECG and troponin normal. So what is the best course of action? Reassurance, invasive coronary angiogram, non-invasive testing for ischemia. So what do you think?
Reassurance. Patient with
Exactly.
very high,
This is reassurance
very
because
low highs.
exactly very low pre-test probability. Yeah. If you do a non-invasive testing for ischemia and it was positive, you get lost. You get lost. لأنه it might not be specific and sensitive and you know. So shall I take the patient to cath lab? نحن we have
We
pushed
can
patients.
use a heart score.
Yes, we can. That's one of the things we can use. طيب, this 70-year-old man with diabetes and hypertension had PCI to LAD 2 years ago, presented this occasion with chest pain, which is burning in nature. Initial troponin and ECG were normal. So, هنا انت you are inclined to choose which one of these three options.
The non-invasive testing.
I don't mind choosing this. Or
Invasive coronary angiogram.
exactly, or invasive coronary angiogram. Both are right, by the way. A 45-year-old lady diabetic presented with effort-induced stabbing chest pain, ECG and troponin are normal.
Also, we can use both. Non-invasive is more.
Here, if you choose invasive, is probably too much because her pretest probability lies right in the middle. Her chest pain is effort-induced, but otherwise kind of possibly cardiac. And she is diabetic, and she's 45, and she is a female. So, يعني, she is intermediate. Intermediate is going to be too much to take her to cath lab right away, but it's going to be unwise to reassure and send her home. Yeah. So in this case, in intermediate risk, you choose non-invasive testing for ischemia. So in high pre-test probability, probably the way to go is coronary angiogram, the low pre-test probability reassurance, and the intermediate pre-test probability for non-invasive testing for ischemia. But you also I want you to be mindful of atypical presentation or the possibly cardiac kind of chest pain, which are, by the way, are more frequent than not. يعني الpatient to present with acute coronary syndrome or chronic coronary syndrome with not typical chest pain is more frequent than not. يعني كلمة typical دي ما قاعد تجي كتير. أنا ما أعرف يعني I think you might agree with me according to your experience. غالبية البيشنت اللي في نهاية الأمر طلعوا acute or chronic coronary syndrome chest pain حقهم when we track it backward it wasn't kind of typical chest pain. And sometimes it might be very, very atypical, like this patient, a 65-year-old gentleman presented to ER with profuse oral bleeding after tooth extraction. The patient has 2 consecutive tooth extraction in a private clinic after he complains of jaw and tooth pain. فقط ما عنده شيء ثاني. He was in ER waiting for the dentist who decided X-ray and admission to secure the bleeding. وده ال ECG حقه. Fortunately, in our ER, ECG is done for all patients. So ECG was done, and I was passing by, and I have seen this ECG. It was handed to me by an ER colleague. So I have seen it, and I said, let me see the patient. So when I went in there, I digged into the history. He said that he had tooth pain and jaw pain, but more during exertion, you see? But when he, unfortunately, when he went to the dentist, he was having kind of tooth scares here and there. So they took this and that, assuming that this is the source of his pain. But in fact, that was ischemic kind of chest pain with radiation to the jaw and tooth with يعني chest نفسه ما كان فيه pain لكن البين كان في radiation site. And we took this patient and proved to have 3 vessel disease. Now, this is a 55-year-old lady. She had metallic mitral valve implanted 3 years ago, presented with chest pain and shortness of breath. She had ST depression in precordial lead and her troponin is elevated at 0.2. Here are her echo, sorry. This is the echo of the patient. As you see, the metallic valve is in here. And you see that there is a large part of the myocardium which is akinetic. And here we are towards the apex, which is severely akinetic, severely hypokinetic. Yeah. So our angiogram was done as a day case, as a case of non-STEMI. Yeah, as a case of non-STEMI because she had chest pain, elevated troponin. And this is the coronary anatomy. This is the coronary anatomy. You see the RCA is fine and dominant, and this is the left main, LAD, and the circ. So normal coronary angiogram. So the diagnosis of this patient is going to be, after you know all of this information, is what? This is stress-induced cardiomyopathy or broken heart syndrome or Takotsubo cardiomyopathy. These are all synonymous terminologies, the most common of which is stress-induced cardiomyopathy, yes? So stress-induced cardiomyopathy presents like acute coronary syndrome. And statistically speaking, 2% of patients who present with acute coronary syndrome turns out to be stress-induced cardiomyopathy. And probably stress-induced cardiomyopathy is much more common than what it actually described in clinical literature. Yes. لأنه الstressors are many, any physical stress, any emotional stress can induce, and the postmenopausal ladies are more prone to it, but now we are seeing it in young and old men and women. You know, it's common, or I might say it's not uncommon, yeah? And when we see the coronaries are normal, this brings us to this terminology, which is now common in cardiology, the MINOCA, which is myocardial infarction with non-obstructive coronary artery disease and ischemia with non-obstructive coronary artery disease. So a patient who presents with infarction or ischemia and his or her coronary angiogram proves normal, this is MINOCA or INOCA. And this might be due to spasm, myocarditis, slow flow, stress-induced cardiomyopathy, a small tiny embolization plugging the distal microcirculation, myocardial trauma, and microvascular ischemia. Yeah. Now, when we look at the ECG and we do our analysis of MI location, we have this blue is the anterior myocardial infarction, the yellow is the lateral, and the green is the inferior. So the blue is left anterior descending artery, most likely. And the yellow here is the circumflex, and here probably the RCA. Sometimes can be the CERC as well. Now, if you look at this ECG, you see that there is very, very extreme ST elevation in the anterior leads and also involving the lateral leads. And this also is another ECG of ST segment elevation on the precordial leads, both of which are myocardial infarction, STEMI, both of which are left anterior descending artery stenosis or occlusion. But do you think there is a difference between this ECG and this ECG? يعني the ECG can diagnose STEMI and the location, but can it tell us about the prognosis? Yes, it can. يعني the extent of the ST segment elevation, okay, the extent, the number of leads involved is one thing. And the magnitude of ST segment elevation is another factor. So when you analyze the ECG, is not just ST segment elevation. No, in how many leads and how much of ST segment elevation you have, this impact prognostication. يعني الآن I expect the ST segment elevation, this one here, okay, to carry poorer prognosis than this one, meaning more necrosis, more proximal occlusion than this one of the LAD. Yeah? So the ECG can be diagnostic and prognostic as well. Now for this ECG, we see ST segment elevation where in the lead 2, 3, and AVF. Yeah, so this is inferior STEMI, inferior STEMI. We also have this tall R in V1 with T-wave inversion. So this is inferior myocardial infarction and can, most of the time can be RCA occlusion, but sometimes can be CERC occlusion. Now, when we look at this one here, where do we have the ST segment elevation? Where do we have it? Look at the precordial leads, look at the laterals, look at the inferior. We are having it at the lateral leads, صح؟ اللي هي 1 and AVL. And probably also 5 and 6, maybe a little bit. This is lateral myocardial infarction, and this is most likely CERC. Can be also diagonal, but CERC occlusion. Okay. Now remember.
دكتور معلش دي South Africa.
Sorry?
Is this the South African flag?
Where is that one?
The last ECU.
This one? This one?
No, lead 1, AVL, still the depression in lead 3.
Lead 1, and AVL.
L.
AV,
It's the depression in lead 3 and V2 also. It is a South African flag pattern.
يعني أنا طبعا ما قاعد أحب الرومانتيك terminologies دي لأنها شوية بتخلينا committed to يعني abbreviate the complexity of the ECG in kind of straightforward shots, which is not the case, by the way. يعني
Okay.
what we are seeing in here is an ST segment elevation in 1 and AVL and probably 5 and 6. And we have reciprocal changes, which is ST depression in the inferior leads. Okay. So this is most likely the CERC occlusion. Here, what is important out of the ECG is first and foremost to detect and pick up the ST segment elevation. That's important, by the way. And it is easier said than done. We have seen patient in ER waiting for hours and their ECG was showing ST segment elevation and the ER physician or even the cardiologist did not detect them early. So you have to look at the ECG carefully and thoroughly. Yeah? مرات لأنه ال ST segment elevation بيكون so subtle. So when you have suspicion, don't leave the patient. Stay bedside, repeat the ECG. How frequent can you repeat the ECG? No rules. You can repeat it every 10 minutes, 15 minutes, half an hour, yeah? Until you pass the stage of this critical, ambiguous kind of diagnosis, and you settle on a diagnosis of being MI or not MI. And sometimes, in controversial cases, you might roll in the echo machine and do echo and stuff like that. So it's not always straightforward, okay? Now, when you look at the ECG, by the way, the ECG is an electric camera. So it picks up or it sees the electrical activity in the heart from different aspects. So we have 12 leads from V1, and the chest lead are from V1 to V6. And we have the limb leads, which are seeing the heart from different sides. The ECG of the 12 lead ECG has two blind spots. So it's blinded to see two main points, which is the posterior part of the heart and يعني شوف لاحظ معي posterior side of the heart is not represented in the 12 lead ECG. The other thing is that the RV, look at the RV. The RV, maybe V1 is a little bit close to the RV and might pick some abnormality from there, but the majority of the RV is not covered by the conventional 12 lead ECG. ولذلك the posterior infarction and the RV infarction can easily be missed in the conventional 12 lead ECG. Okay? طيب, can we do anything about that? Yes, we can. أول حاجة تذكروا the mirror image بمعنى إنه إذا كان عندك in V1 and V2 عندك tall R and ST depression and upright T, this is considered to be STEMI of the posterior aspect of the heart. لأنه بيقول لك this is mirror image بمعنى if you flip the ECG the other way, this one is going to be Q wave, this one is going to be ST elevation, this one is going to be T wave inversion. But this is an indirect way of diagnosis. The direct way is just to take 3 of the leads from the chest, put them posteriorly. So you have to flip the patient the other side and put these leads, which are now V7, 8, and 9. And you are going to see if there is infarction there in the posterior aspect of the heart, you are going to see ST segment elevation. And you don't have to go for the hypothesis and the indirect evidence of mirror image. So look at this one here. There was mirror image here. Yes. But when they put the leads 7, 8, and 9, it's clear ST segment elevation. So now this is clear posterior myocardial infarction. Now for the RV, again, we have the same problem. And to confirm that you have RV infarction, especially in a patient who comes in with raised JVP, and probably hypotension, you have to suspect RV infarction in context of inferior wall MI. So in this case, just place 3 of the leads on the right side, and now they are called V4R, V5R, and V6R. And you see the Q wave and the ST segment elevation, and this proves you have RV infarction. So for the RV and the posterior, we have to go unconventional by using unconventional leads, which are posterior leads, right-sided leads, okay? And when we come to the T wave, when you look at the ECG for T wave, we have this T wave, which is symmetrical, narrow-based, and pointed of hyperkalemia. We have this one, which is symmetrical but broad-based and not pointed. This is hyperacute T wave of ischemia, and maybe the forerunner of myocardial STEMI. يعني البيشنت ده اللي بيجي chest pain وعنده hyperacute T wave, after some time it may become ST segment elevation. So in this patient, you have to repeat the ECG frequently. And when we have tall R wave but asymmetrical, this is considered early repolarization and normal variant and has no clinical significance, arguably, although some people think, no, it has a clinical significance, but not ischemia kind of problem, okay? When we analyze the ECG for ST segment depression, it's not a matter of present or absent, but morphology of ST segment depression. Is it up-sloping like this, or down-sloping, or horizontal? If it's down-sloping like this is the most specific of ischemia, followed by this one, and least by this one. Up-sloping is not specific for ischemia. Yani it can present as a normal variant. Now, the problem is with the T-wave inversion. T-wave inversion is far less specific than ST depression بكثير وبتحصل في conditions كثيرة جدا in ischemia, acute and chronic, in CVA and intracranial insult, in Hookhams and hypertrophy, in myocarditis, and can be normal as well. Yeah. فبالتالي T wave inversion الاناليسيس حقها is a bit tough, okay? But remember the ST segment depression, you have to decide about how the morphology is. Okay. Now we have this 62-year-old male admitted 3 days ago with anterior wall MI, and he was stable and due for discharge next morning when he developed severe shortness of breath and became hypotensive. So what do you think? This scenario points to what? It points to
Mechanical complications.
exactly. Mechanical complication of MI. So the first week post-myocardial infarction is the week of mechanical complication. It is so unlikely that patients develop mechanical complication 1 week after MI. ممكن تحصل, لكن it's so less probable. Okay? But in this scenario, this is mechanical complication. The first thing to do after you support the patient hemodynamically is echo. And we are seeing here, you look at this piece of meat attached to the cord, you see it here. This is a ruptured papillary muscle, and this is severe mitral regurgitation, yeah? Severe mitral regurgitation. And by the way, because it's acute, the clinical exam to induce the typical murmur of MR might not be so pronounced. It is very subtle murmur, soft murmur, because of the acuity of the MR and stuff like that. So the murmur isn't so loud. فبالتالي هنا يعني the clinical exam might not be helpful. You really have to do echo whenever you suspect mechanical complication. The other thing is that you can have VSR, and they call it VSR, which is ventricular septal rupture, and not VSD to distinguish it from the congenital type. So the congenital type is VSD. Now the MI-induced rupture is VSR, which is here, and it can occur anywhere along the septum, basal, mid, or apical septum, and you see it here. Fortunately, clinically, it's easily detectable because it is associated with loud murmur and thrill, yeah? So you put your stethoscope, you can hear a lot. Not like MR, papillary muscle rupture. In papillary muscle rupture, the murmur is subtle. We can also have this unfortunate complication of rupture, which is pseudoaneurysm with pericardial effusion. This LV thrombus is not considered mechanical complication. This is one of the complication of MI, but it's not leading to shock. It can lead to embolization, but not to shock. So the mechanical complication basically refers to papillary muscle rupture leading to severe MR and ventricular septal rupture, okay? 21-year-old lady, no past history of note, presented with shortness of breath and dizziness preceded by flu symptoms. On clinical exam, she was agitated, cold extremities, raised JVP crepitation up to mid-chest posteriorly, hypotensive, tachycardic, apical pansystolic murmur, no pedal edema, and this is her chest X-ray. You see that they are central line intubated, so many cables indicating how serious the patient is. So what do you think?
Dilated cardiomyopathy?
So is she in heart failure?
Yes, with raised JVP.
Exactly. Exactly. You are right. So this is heart failure and de novo heart failure or new onset heart failure because we have no idea how the patient was, and to the best of our knowledge, this patient was so normal with no complaint and no past history of note. So this is heart failure de novo or new onset heart failure. And according to the ejection fraction, you know that heart failure with reduced ejection fraction if the EF is less than 40, and with preserved ejection fraction if the the ejection fraction more than 50, and mildly reduced when it is between 41 and 49. So according to the ejection fraction, we now have three phenotypes of heart failure with reduced ejection fraction, with preserved ejection fraction, with mildly reduced ejection fraction. So our patient, we don't yet know what type up until we do the echo, and her ejection fraction was 25%. Now it's so important as well to do this classification of heart failure according to congestion and perfusion, because this has an impact on the therapeutic plan. Okay, so is she cold? Is she warm and dry, warm and wet, cold and dry, and cold and wet? Warm and cold relate to the state of perfusion. Wet and dry relates to the status of congestion. So if she is warm and dry, this is the best. If she is cold and wet, this is the worst. Cold and wet meaning low perfusion and congestion. Warm and dry meaning good perfusion and no congestion. And in each one, the treatment is different. Okay? Now, also remember that congestion is not all or nothing. When you look at the chest X-ray, you don't expect to see this florid pulmonary whiting out and pulmonary edema. Look at the chest X-ray analytically and carefully, because the congestion is grades, not just all or nothing. You can have this upper lobe diversion, which is early stage of congestion. You can have also careless B-line, which are in here. These are interstitial edema in the fissures and all of this. This is an early stage. We can also have this hilar filling, which is a moderate stage of congestion, which increase to kind of bat wing appearance, and then this whiting out. So the congestion is a matter of grades, not a matter of present or absent, okay? And also remember that decompensated heart failure in a patient who is known to have heart failure and now comes in with congestion, low perfusion, congestion, and all of this is called decompensation. And decompensation is very unfortunate event. Why? Because anytime the patient decompensate, he's gonna go as down as this one here. He might die in this index hospitalization. But even if you manage the patient and you successfully discharge the patient, he will never go back to his or her baseline. He is gonna keep going downhill. So each and every decompensation adds to the patient mortality. And in decompensation, we have to elicit the precipitating cause for this decompensation. Is there any ischemia, problem of compliance and adherence, salt intake problem, arrhythmia, myocarditis, uncontrolled blood pressure, anemia, infection, medication like non-steroidal, steroidal, thyroidal dysfunction, renal failure, pulmonary embolism. You have to. This is part and parcel of clinical analysis for any decompensation, is to elicit precipitating cause or causes. Important. A 45-year-old male, no past history of note, except he has been told he is hypertensive 1 year ago, but did not accept medication, preferred lifestyle modification. Presented with 3 days of increasing shortness of breath, blood pressure is 185/100, heart rate is 65 beat per minute, creatinine is mildly elevated, his chest X-ray is congested as shown below. So as you see here, there is a clear upper lobe diversion and filling of the hilar. So this is kind of moderate congestion. So what do you think? How are you gonna describe the diagnosis here? This is malignant hypertension, hypertensive emergency. Malignant hypertension, hypertensive emergency. So malignant hypertension, which is also called hypertensive crisis, can be hypertensive emergency if there is end organ damage in the brain, heart, eyes, kidneys, and or hypertensive emergency if there is no end organ damage. So in this patient, we have high blood pressure, but we also have what? Mildly elevated creatinine. So it's considered kind of nephropathy, and congestion, which is kind of heart failure. So we have in-organ damage. So this is malignant hypertensive emergency, and the treatment is in hospital with, you might initiate the treatment with IV antihypertensive, but you have to be judicious in using that, and you have to titrate the medication so as not to lead to precipitous fall in the blood pressure cautiously. Remember that hypertension leads to LVH, ischemic heart disease, as the risk factor. Heart failure with preserved ejection fraction, but can also lead to pulmonary hypertension. Different forms of arrhythmia, especially atrial fibrillation. It can weaken the heart to the extent of inducing heart failure with reduced ejection fraction. It can lead to mitral regurgitation, which can be severe due to AF remodeling, atrial remodeling, and atrial mitral regurgitation. It also affects the progress and severity of aortic stenosis. If you have uncontrolled hypertension for a long time, this will accelerate the process of degeneration of the mitral aortic valve and leads to earlier development and severe development of aortic stenosis. It can also dilate the aortic root and affect its functionality, and this may lead to aortic regurgitation and can also induce aortic dissection. So hypertension, you have to look at it broadly. How disturbing to have high blood pressure in one patient. From cardiovascular perspective, the list is far from exhaustive. Now, this is an ECG of LVH. Yeah, we are seeing non-specific IVCD, which is intraventricular conduction delay, because it's a bit broad. But you see here the height of the QRS complexes, and we also have a strain pattern as evidenced by the asymmetrical T-wave inversion. How we diagnose LVH? So many criteria, the most important of which is V1 and V2S in S wave in V1 or V2 plus R wave in V5 or V6 more than 35 millimeter, that is LVH. And LVH, if we compare the biopsy of a normal thick LV, it looks as this. When there is a hypertensive LVH, it is fibrotic. So there is interstitial fibrosis. That's the problem of hypertension. When it leads to LVH, LVH is not benign at all. It induces intramyocardial fibrosis, and that might be the cause of arrhythmia, heart failure, and all of the disastrous consequences of hypertension. 33-year-old lady with no past history of note, uneventful cesarean section 2 days ago, developed sudden chest pain and shortness of breath, heart rate 135, blood pressure is low. Patient then developed PEA, pulseless electrical activity arrest. Fortunately, after 13 minutes of ACLS, she has ROSC, return of spontaneous circulation. Echo is requested. Is echo appropriate in this scenario? Yes or no?
Yes, we can see left ventricular straining, right ventricular straining.
Exactly.
Yeah, right
Remember, we
ventricular.
said, yes, exactly. We said emergency echo. One of the indication of emergency echo is proven or suspected pulmonary embolism. Yes? And remember, this patient is, some people might say, "Yahi, echo after arrest is not so, making sense." No, it does make sense. We know the H's and T's, right? We have 10 of H's and T's, 4 of which can be diagnosed by echo. Hypovolemia, if we look at the IVC. Thrombotic coronary occlusion, if we look and see regionalities and stuff like that. And also tamponade, okay? And also pulmonary thrombosis, if we look at the status of the RV. Like you said, if we see an RV like this, yes? If we see an RV like this, RV here is dilated, and here is dilated, and we also can demonstrate the so-called McConnell sign, which is apical hyperkinesis, while the base of the heart and the mid part of the RV is hypokinetic. That's why McConnell sign is RV apical sparing hypokinesis. So the RV is hypokinetic apart from the apex, which is normal or hyperkinetic. This is a specific sign of pulmonary embolism. And you see here how big the RV is, how compressed the LV is. And sometimes we can see a thrombus in the right side or in the pulmonary artery. So echo is important. Echo is paramount. And ECG, the most common finding in ECG in pulmonary embolism is not S1Q3T3. It is non-specific changes with sinus tachycardia. But the classic teaching is S1Q3T3, which is S1 is here, Q3, and T wave inversion in lead 3. Yes, it might be more specific, لكنها not common. We can also have new incomplete or complete right bundle branch block as a sign, ECG sign of pulmonary embolism. Now the last thing, and I think you might have a dedicated presentation on acute aortic syndrome, but remember a patient who presents with tearing chest pain that radiates to the back with differential blood pressure, and this chest pain is spreading. يعني البيشنت بيقول مثلا مرات يجو chest pain, now he feels it in the upper abdomen, now in the mid. That is so classic of dissection, because at the intima it sloughs off downward, the chest pain spreads where the tear is going. Yeah, and we have type A and type B. Type A involve the ascending aorta. Type B is below the left subclavian. And type A is a surgical emergency. Type B goes for conservative therapy unless there is indication for surgery. And if we look at the echo here, echo is also helpful because we see the flap. That's the flap. And the flap sometimes interferes with the function of the aortic valve, might lead to AR. And here also is a dissection with a dilated root. And here is the ascending aorta is fine, but look at the descending aorta. So this is type B dissection, affecting the descending aorta, but not the ascending aorta, okay? And like we said, the management, and as far as chest X-ray is concerned, you are gonna demonstrate a wide mediastinum, but most importantly, the clinical data. Remember, the pre-test probability of any investigation you are going to request depends on how firm your clinical grounds are. So always try to gather as much and as more information, clinical information as possible before you initiate any investigative workup. Okay, by this I conclude and thank you so much. I'm open to all questions if you have.
Thank you very much, Ustazna Dr. Hatim, for this very elegant talk as usual. شايف أستاذنا دكتور عبد الرحمن زيادة وأستاذتنا دكتورة صفاء حسن طيب وبروبلي أستاذنا بروف الباشا are here. I think any one of them can start to comment or to talk. Please welcome أساتذتنا الأفاضل. مرحبا بكم.
If I may start, السلام عليكم.
عليكم السلام دكتورة صفاء، تفضلي.
بارك الله فيك. حاتم خير الله كفيت ووفيت. I think this is a very exhausting task. You were assigned the most difficult topic by far in cardiology, acute cardiac emergencies, and I think you could not have done any better. You actually squeezed all the imaging and invasive modalities to ascertain, and each and every one of those topics is good enough to be a lecture on its own merit. But it was very well executed. I do have to comment and to commend the quality of the images. The echo images is just superb. They are superb, and I'm sure they're all coming from Hatim's own experience. I don't think he got anyone or those out from the media or artificial intelligence, or probably ask any one of the colleagues. لأنه حاتم is well known to have the most extensive atlas of cardiac imaging, especially echocardiogram. Well done, ya Hatim. And if I may get the permission or to ask Dusugi to get Hatim to talk again in a subject of his own liking, to dissect and tell us more about it. It's always interesting to listen to Hatim. I think Hatim is driving the lecture on a slow profile or a slow note. لأنه Hatim, if he decided to drive بgear 5, it would be very difficult. فحاتم has this talent, mashallah, to take the gear up and down. And we are seeing the very low gear, the 2 or probably 3. I cannot wait to see the when he drives into 5. Well done, Hatim.
Thank you so much, Dr. Safaya. It's always amazing and nice to hear from you. And this commitment, يعني I'm so humbled by it. لكن يعني تظلي أستاذتنا وشهادتك أحترمها وحقيقة I feel delighted to hear that from you. وإن شاء الله بإذن الله أكون عند حسن ظنكم دائما. وبعدين طبعا يعني مع أستاذتنا صفاء معانا دكتور زيادة. طبعا دكتور زيادة هو من ورطني في الكارديولوجي يعني. و... وانا مبسوط جدا والله يا دكتور زيادة بشوفتك يعني حقيقة. شكرا يا دسوقي والله العظيم. يعني اليوم ده انا ما اعرف حقه توقف الريكوردينج بعد يا دسوقي.
اوكي.
الموضوع حيجيب بكا واشياء كده ما حلوة.
السلام عليكم يا دسوقي، إذا كان ممكن أتكلم.
عليكم السلام
طبعا
استاذنا
يا برادر.
الفاضل، طبعا اكيد تفضل.
سلامات عبد زيادة، كيف أحوالك؟ إن شاء
الله
الله بخير
يسلمك.
مع البرد
الحمد لله
القارس
رب
في
العالمين.
بريطانيا.
والله the temperature now is -3 last night. والكنالز هنا في أمستردام are covered by a layer of thin ice. أنا I'm sorry يا حاتم I arrived late لأنه أنت you pulled your talk back وبقت coinciding with صلاة الجمعة هنا. لكن anyway, I am quite confident that what has been delivered while I was away is more than enough, because I have had the experience of listening to you on several occasions, and I am so pleased that إنك أنت في المؤسسة الضخمة فعلا العسكرية هناك أو مدينة الأمير سلطان, that you have gone through to lead in so many ways, particularly in the process of educating others and educating the chaps in the chaps and ladies in the fellowship program. أنا زي ما قلت لك وصلت متأخر, لكن I just wanted to see whether we can في السودان think of implementing the line of thought as it comes into the rush protocol and the fate protocols, which are 20 years old now, and they do cover all the aspects on why patients, how patients present acutely with cardiac problems, or in the way of finding out whether their problems are cardiac or not, and equally on determining and planning the treatment. And ECHO, or those two protocols, I'm sure you have gone through them or on your own way completed them. لما كنت في مركز الأمير سلطان لما كنت في مركز السودان للقلب الفترة البسيطة اللي قضيتها هناك, I decided that one of the echo machines should be stationary in the CCU, and perhaps to some extent in the ICU. And the reason for that is I wanted people to have the fellows particularly to have the experience of immediately assessing the patients with echocardiography, and equally to promote the process of thinking of an acute problem using those protocols, which are probably now about 20 years I'm not sure whether people were enthusiastic in doing that at that time, and I don't think I have gone in my own way as far as implementing this as a process, in the process of thinking about an acute cardiac emergency. Anyway, Hatim Safa, you know what I think the state of echocardiography in Sudan, and I feel that there is a huge potential, particularly that now we have people who are enthusiastic about teaching. And again, thanks to Disugi. In fact, I am quite happy that Disugi has moved the center of attention to cardiology in general and to Al-Ubaid. And Al-Ubaid deserves it, particularly in the circumstances of war. Hatim قبل كده suggested that they design or construct a fellowship for echocardiography in Sudan, and I saw this as a suggestion, and I'm not sure as to how far it went, but as it is in Sudan, it might materialize in 20 years' time, but we should soon be different people and have stronger enthusiasm towards doing these things, because we have to now think seriously that the floor is for the fellow that comes into the business as new for the future of cardiology in Sudan, اللي هو, as I might say, or since the 60s, it has been in coma for a long time and only revived somehow 10 years ago. لكن الemphasis again wasn't in what is extremely useful and which concerns almost all patients with cardiac problems, and that's imaging and echocardiography. So thank you very much, Hatim, for this talk, and I hope these talks do not stop, and I hope that you don't bring the time forward, لأنه while أنت بتكون جاري لاحق لك سماية ولا حاجة في الثمامة، نحن جاي بنكون في الصلاة. again, greetings, real greetings, Lady Sugi. Thank you for this. You now acquire a position of leadership in the process of education, and I'm pleased to hear that. تحية لك يا حاتم ولأسرتك الطيبة الكريمة ولمركز الأمير سلطان جمعا. I hope I haven't taken too long.
Thank you so much. Thank you so much, Dr. زيادة, أستاذنا العظيم الجليل. وحقيقة يعني we are all so honored to have you on this platform and for sharing these enlightening insights about the ways forwards. وأنت أستاذنا وحكيمنا وستظل دائما. As to the fellowship program of echocardiography, we have started and we have written the full proposal, which align with the circumstances of Sudan before war. I don't mind, طبعا the situation has changed dramatically, but أنا حقيقة I encourage and I'm amazed by how you insist, okay, to stand up from the ashes and vehemently working really so hard, okay, despite all the challenges. يعني الموضوع ده is so inspiring to all of us. دسوقي, thank you so much. I suggest, بما إنه معانا دكتور زيادة, إنه we task force the echocardiography fellowship program one more time. If we can sit together and try to plan and propose how we can conduct a fellowship program of echo, لأنه like Dr. Ziada said, this is one of the major deficiencies of cardiology service in Sudan. Okay? We can, and I promise you, I can take the lead in this. وإن شاء الله دكتور زيادة يكون معانا ودكتورة صفاء ومعكم جميعا best of luck إن شاء الله دائما.
السلام عليكم.
عليكم السلام
عليكم السلام
أستاذنا
الباشا.
الفاضل.
الحمد لله، كيف أحوالكم؟
اتفضل أستاذنا الفاضل الباشا، مرحب بك.
والله أنا طبعا يعني بروتوكوليا ما المفروض أتكلم وراء أستاذنا عبدو زيادة وأخونا الكبير يعني الشخص الذي أعطى ولم يستبق شيئا والشكر أجزله لأخو الصفاح اللي هي دائما يعني قلبها على بلدها. يعني صعب علي والله في الكلمات حقيقة، نيابة عن الناس الموجودين في السودان بيقدموا سيرفيس، الناس اللي في التريننج. الكلمات لا تفي حاتم والله بصراحة أنا أقول لكم يعني. حاتم مع الفولو زي هي ستارت with them from scratch يعني، والفولو أسع بقوا الحقيقة يعني. دي أنا ذا بيست تيست الزول ممكن يقولها. السيرجون ناس محمد زين وعمر نعوف يعني زي هاي كاليبر سيرجون بقوا ما بيجونا احنا للفالف بيفتكرون احنا زي ما بتقول صفا احنا شفقانين ما بندي الايكو وقته. بيقعدوا الفولو بيدوهم يعني هاف ان اور اقل حاجه يصطدي للعينين الماشين فور بري اوبريتيف سيرجري وحاجات زي دي. ودي شهاده انا افتكر حقيقه يعني شهاده قال عن الفولو شيب اللي هو بدو زي ستارت فروم نثينج، لكن بفضل حاتم، بفضل صفاء، بفضل المحاضرات اللي تقدم دي العمل قام. ودي حقيقة يعني احنا نيابة عن الكارديولوجيست في السودان، نيابة عن انا از ديسيجن ميكر في السيرفيس الزول بيقدم السيرفيس في السودان، انا لا اجد الكلمات اللي بتشكره على ما يقدمه لبلده. والفولو they are very grateful ليك، والله لازم تعرف المعلومة دي تماما يعني. very grateful ليك، very grateful لللكشة اللي اتقدمت قبل كده، اللكشرين 3 قدمتها اخوتنا صفا وزي في الزقاب. لكن والله كنت الحاجة دي برضو دايرة تصل للديسيجن ميكر في البورد يعني، زي ما عارفين العمل بيقدم. الحق يقال يعني. المعلومه افتكر من حاتم ومنك انت يا دسوقي ومن اخوتنا صفاء من عبدو تصل اللي هي دكتور نوال هي الهيد اوف ذا بورت، عبد الباقي في التريننج يعني. بيجيبوا لنا حاجات يقولوا تفيد قبل، لكن لقينا احنا كلها دي اتقدمت باي ذا مره ولا مرتين. انا يعني اول حاجه فرصه طيبه بجد انا اتكلم عن الاقي اخونا عبده والاخت الكريمه صفاء، ونيابه عن الفولو انا لا اجد قلت لك الكلمات اللي بيسوي. اما عن الدسوقي شهادتي فيه مجروحه. الدسوقي ده جابته لي بتذكر لا ساعه الدكتوره فاطمه، تذكر الدسوقي
نعم
از ريجسترار قالت لي
نعم
زول ده زول ريجسترار ميديسين الوقت بكمل الاثنين. قالت لي يشتغل معاك، يشتغل معانا ثاني جاء في الكارديولوجي، وشهادتي فيه مجروحه تماما. وانا افتكر ام فيري براود انه الفellowship خرج الزول زي الدسوقي. المحاضره اللي بيقدمها حاجه دي بالمناسبه قال لي شيء اسبوعين بتقدم ومرتين توايس بير ويك، وما حصل في محاضره ما قدمها واتاخرت لاي سبب من الاسباب زي ما قلت ماشي ثمام اللي ثمام حاجه زي دي الا عوضها. الشكر يجزله يا جماعه. وانا نيابه عن كلكم انتوا في الفاميلي بتاع القلب بتاع السودان تشكروا حاتم. اما موضوع الايكو والايمجنج يا جماعه والله تز هاي تايم فعلا يعني يا صفاء. احنا ما شاء الله عندنا ناس ريفرنس في الايمجنج بجد يعني، وما بتكون عندهم اي مشكله انه تفل التريننج. وبقينا عندنا الاشياء يعني دخلت يا جماعه 10 ايكو ماشين وذ بروب جي اي فيرست كلاس داخلات الساعه يا جماعه 6 قطارات بالمناسبه الان في السودان حيمشي يشتغل يعني. السودان يبدا من جديد، وان شاء الله حرب تقيف وكلكم ترجعوا لبلدكم يعني. ومرحب بكم، شكرا جزيلا يعني.
شكرا
بفهمي
جزيلا.
كومنت يا صلاح يعني. دايما كلمات زي دي يعني it's more of responsibility لنا يعني. it's not انك تقعد انه واحد فينا يقعد in his comfort zone from a distance ويجمع الكيسز اللي عنده ويديها. طبعا ده جزء من البروتوكول او جزء من التريننج، لكن التريننج انت براك عارفه you have to get your hands dirty. يعني كلامك ده انا دايما كل لكشر انا بطلع بانه يا جماعه نحن بعيدين، نحن between two bracket trainers and seniors حاتم myself سحر أنس. you can't imagine نحن on almost daily basis we exchange painful messages between ourselves إنه يا جماعة نحن 200 قبل ما يدركنا. خلي أقول لك ما أقول الموت، ما أقول العجز، ما أقول الريتايرمنت، ما أقول كده، إنه زول while he is able to give 200 ندي ديننا in full. أنا ما أعرف يا دكتور صلاح، خلينا نخط النقط فوق الحروف. Do you think إنه عشان to get the ball rolling هل في ما يمنع إنه نعمل جدولة والجروبات بتاعت الكارديولوجي كبيرة، جدولة لكل واحد فينا who is able and interested إنه تنزل في إجازاتك، تنزل في your time back، تنزل إن شاء الله كان 10 days to train people. في النهاية العلم ده ما نحن مسؤولين منه، ما هي زكاة أنت بتأديها بتسأل منها. أنا مشور out of at least لو ما 10 out of 10 بيكون في at least 7 they are willing to come down، يمسكوا لهم ناس. انت عايز البريد بتاعك زي ما انت علمك زول، انت عايز تعلم زول والزول ده يعلم زول، والعلم بيكون continuous. فالليكشرز دي حبابة it has to continue. لكن خلينا مثلا اسال يا الاودينس ال 36 القاعدين ديل، منو في ال 36 ديل is a fellow and confident enough انه to sign a report انه this is an LAD territory infarct, this is a massive pulmonary embolism with RV strain, this is a aortic dissection that needs urgent surgical attention, this is apical hypertrophic cardiomyopathy, this is hypertrophic cardiomyopathy, this is cardiac amyloid. الديسيجنز دي عشان تخطها confidently وتبصم بوراها بالعشرة، منو is confident to do that؟ اذا ما لقينا زول ده ما قصور منهم، ده قصور مننا. زي ما نحن تعلمنا نعملها لازم نعلم الناس يعملوها. نحن دايرين آلية بتاعت إنه we start doing things we have to go. أنا أفتكر the best way حاتم ده yes الليكشر دي زي ما أنا قلت it is so full it is so rich، لكن I'm sure إنه في كمية من الناس الحاضرين ديل عايزين حاتم ده عطبرة ود مدينة الحديد والنار ينزل فيزيكلي ويكون معاه 10 من القاعدين ديل يمسكون البروب امسكوا البروب ده كده manipulated كده، جيب الار في ايمج بالطريقه دي، جيب الستريم بالطريقه دي، احسبها كده، خط الريبورت بالطريقه دي. it is easy انك تشوفها اونلاين في ليكشر، لكن تو براكتس ات وتكون عندك الكونفيدنس انك تعملها. ما هو ده الكونفيدنس اللي خلى السيرجن اللي قال عليهم صلاح الباشا بيبقوا يجروا على الفلوس عشان بيدوا الاشياء وقتها وحقها ومستحقها. صلاح انا افتكر we have to get things moving، ما بود ما بشحده باوردر. يا جماعه we need to get things in writing. خلونا نخد جروبات those who are keen and those who are able. let's get down ننزل والبيك اب حرروا اهله، ما حتجيب لك ناس من برا ولا from a distance. that's what I think والله. والامر اليكم فانظروا ماذا تروا. شكرا.
Actually, Sugi, I don't want to hold the talking from others, taking too many opportunities. لكن
تفضل
I
أستاذ.
just want to بما إنه ذاته كمان صلاح الباشا موجود, I have to emphasize the fact that the performing a medical procedure or going through a medical thing is a process of training. وأولاداتنا دول في السودان أنا أؤكد لك if you give me 10 of them and you give me a structured training program, structured with venue or facility, in addition to the fact that selected trainers who know how to get things into the learning curve, I am sure 9 of them will succeed, and one of them might fail because of his personal circumstances. وبالتالي things has to go into the structure, a structure which is eventually certifiable, following assessment and exam and ongoing assessment during التريننج ذاته. It has to be that way يا صلاح. لا يمكن أن تكون بين والله فلان اجتهد براه ولا فلان عمل براه ولا فلان حضر lecture. نحن we want people to be humbled by knowledge, not to feel that they have done it all and had it all. So it has to go into the structure. وأول structure that has to have something certifiable inside it is the fellowship program. لأنه ما تنسوا بعد شوية نحن حنمشي، والحقيقة بدينا نمشي على عكاكيز، والدنيا ماشية سريع جدا زي ما صفاء ورت في اللكشر بتاعة القيمة. الدنيا ماشية سريع جدا ونحن too slow for it and we have long holds. مرات حريب، مرات إمكانيات، مرات إلى آخره إلى آخره. It has to be structured, certifiable, if you know what I mean. Thank you very much.
Thank you so much أساتذتنا الأجلاء. وأنا بس just echo what دكتورة صفاء mentioned إنه and I think all the senior consultant cardiologists Sudanese يعني in the diaspora are duty bound to serve their country and their people, and this is the least we can offer, and nothing at all above and beyond the call of duty of what we are doing here at all, by the way. بس هي الموضوع زي ما قالت الدكتورة صفاء, it needs to be more, ودكتور زيادة, it needs to be more structured, more encompassing, more organized, وفيه physicality. اوكي, فإذا نحن جلسنا كناس يعني شايلين الهم ده في التريننج في السودان, إذا جلسنا together اوكي مع كل الناس الموجودين زي ناس دكتور صلاح الماسكين الجمر بشدة هناك, ونحن اللي بعيدين شوية, على أساس إنه نصل إلى مقترحات تكون practical of how to enrich the training and how to go on with the training in more structural way and in more encompassing ways لكل القدرات اللي عندنا in the diaspora and locally. اوكي, فأنا حقيقة I urge people إنه نحن we team up and we come together in a brainstorming session initially, نحدد كيف ممكن نتحرك إلى الأمام فيما يخص التريننج, and not to wait for أي new circumstances to unfold. We get to start right now. اوكي, فبفضلكم جميعا أنا I'm so optimistic إنه وأنا I have always been optimistic and confident that the Sudanese human resources is the biggest treasure we have. Okay, how we just got to invest on this treasure is a matter of our will, and I think we are willing to. So just let's get started.
شكرا جزيلا يعني لأساتذتنا الأفاضل.
السلام عليكم.
عليكم السلام، تفضل.
السلام عليكم أستاذ الفاضل. حقيقة يعني ما سمعت من محبة واحترام لأساتذتنا لبعضهم، يعني ده بيخلينا احنا ذاتنا يعني نحترمهم ونقدسهم، وده أصلا ده يعني ده يعني ماشي في الفلوسفي في الكارديولوجي، يعني مما بدينا لحد الآن يعني ما في أي شرخ غير الاحترام والمحبة وسعي الناس وسعي الأساتذة لتقديم المعلومة المفيدة. والفولوشيب الحمد لله البروجرام موجود والناس ماشية، لكن السب سبيشالي ذاته في البروجرام ايكو انترفنشن يعني دي لازم تكون موجودة، يعني لأنه ما في ما يمنع، لأنه الفوليوم بتاعت العيانين موجود والخبرة موجودة، وبالتالي ما في حاجة تمنع إنه الإيكو والإنترفنشن يبدو إيرلي، بعدها تبدأ الدايجنوستيك الإيميجينج ممكن بعدك تبقى ليتر أون يعني. لكن الحاجتين دي الإيكو والإنترفنشن أنا أتخيل ما في مانع إنه يتأخر أكتر من كده، لأنه الآن ماشيين على الدفعة 13 أستاذنا صلاح الباشا، ونحن ما عندنا ايكو بروجرام ولا انترفنشن سب سبيشاليتي، لانه يعني السراوندنج اللي حوالينا كلها يعني محتاجه لخدمتنا يعني. ونحن عندنا ملغمات في الانترفنشن وفي الايكو، وما في ما يمنع انه تبدو الاثنين دي مع بعض ونستمر عليها، لانه الان انا موجود الان خارج الهند لسب سبيشاليتي وبدفع $6000. يعني $6000 دي كان اولى بها زول اجنبي يدفع للسودان للمراكز بتاعنا يعني. فالحاجه دي يعني ما صعبه، زي ما قلت لكم الفوليوم بتاعت العيانين موجود والخبره موجوده. زمان الناس لما كانت في السعوديه كانت الMRCP كان سوبيريور على الMD السودان، لكن لما بقى فيه براكتس لما عايروا البراكتس بتاعت السودان خلوا الMD بتاعت السودان سوبيريور على الMRCP. الان برضه نفس الشيء، الاعتراف موجود الفلوشيب بتاعت السودان في الكارديولوجي، فليه ما يكون برضه يعني